I'll be presenting our study, a retrospective study on clinical significance of prechoroidal cleft in eyes with exudative macular degeneration conducted in Arvind, Chennai. So prechoroidal cleft is a hyperreflective space sandwiched between the two hyperreflective bands on the OCT, that is the RP neovascular band and the Brooks membrane, as you can see here. And it's also characterized by posterior bowing of the Brooks membrane. In literature, the incidence reported in Asian population was around 10% or 8.1% and was seen to be more in males in unilateral and in more in PCV cases. In Caucasian population, the incidence reported to be around 15%. So the objective of our study was to investigate the prevalence, risk factor and clinical significance of cleft among the exudative macular degeneration patients, which included neovascular AMD patients and PCV patients, and to investigate the response of cleft to treatment, investigate and compare the response to anti-VEGF therapy in macular degeneration patients with and without prechoroidal cleft. So study participants were the patients who presented to our OPD in January and February 2023 and were diagnosed with exudative macular degeneration with minimum follow-up duration of 6 months. So we screened 215 patients who were treated with anti-VEGF macular degeneration patients and had minimum 6-month duration follow-up. We looked into the BCVA and logMAR scale, lens status, number and type of injection, fellow eye condition. OCT were graded at baseline 3 and 6 months for the presence of prechoroidal cleft, central subfoveal thickness, maximum retinal thickness, pigment epithelial detachment, intraretinal fluid, subretinal hyperreflective membrane presence or absence. Excluded were the patients who had any previous PPV or any concomitant macular diseases, any other ocular conditions compromising visual acuity or severe media opacity. These were the statistical analysis used. So in our study group, of the 215 patients which we screened, we divided into cleft and non-cleft group. Cleft group patients, there were 21 patients and 21 in the non-cleft group. So our incidence was 10.23%, which was similar to other Asian studies. Mean duration for cleft development we found to be around 12 months from the time of presentation. 18 eyes in the cleft group, CNVM was active at the time of development of cleft. That is, 85% of patients, CNVM was active when the patient presented with cleft. The mean age was around 71 in both the groups. So our patients were mostly of neovascular AMD. There were also 10 patients of PCV, 5 in cleft group, 5 in non-cleft group. RAP, we had 1 patient in cleft group. So the visual outcome at baseline, 3 and 6 months and final vision, they all showed statistically significant difference between the cleft and without cleft group, with the patients with cleft group having poorer visual outcome. Coming to the anatomical outcome, at baseline and at 6 months, there was a statistical significant difference. Patients in cleft group had thicker CSFTs compared to the non-cleft group. Similarly, for maximum retinal thickness, at baseline 3 and 6 months, all was found to be statistically significant, with cleft group having thicker MRT. Intraretinal fluid was significant only at 6 months, with cleft group having more of the patients in the cleft group having presence of IRF. PED height also we measured between the two groups, but they were comparable at baseline 3 and 6 months. SRF were also comparable. However, presence of SRF 6 months was more in cleft group compared to non-cleft group, but it was not statistically significant. Number of injections received in cleft group was again significantly more in the cleft groups, but it was not statistical significance. P-value was more than 0.05, but we can see cleft group received 165 injections comparatively. Cleft disappeared in 5 cases, but it reappeared in 2 of these cases associated with disease activity. At last visit, cleft was present in 16 cases, that is 76% cases, and 10 of those with presence of active neovascular disease. During last follow-up, all cleft cases with active CNVM, cleft was persisting. So our study showed the incidence to be 10.23%. Eyes with cleft received more injections, had poorer visual outcome, and was associated with thicker CSFT MRTs and more presence of IRF, and it correlates with the disease activity. All cleft cases with CM activity had cleft persisting at final visit. In literature also, other studies have reported CSFT MRT to be thicker in cleft. However, IRF was not significant, but we found IRF in 6 months. SRF was significant at longer follow-ups of 2 years. They have reported PD had to be greater, but ours was not so significant. Number of injection in cleft group was more in other studies also. Comparatively, our study also had more number of injection in cleft group. Cleft regression was 28% similar to ours, and reappearance was 50% after treatment, similar to ours. There's conflicting reports in literature. Some say they're on visual acuity. Crady et al., Cozy et al. Have said there's no influence. Kim et al. Have, there's poorer prognosis. Similarly, we report poorer prognosis in patients with cleft. So this prechoroidal case is required. We like to conclude saying they require more closer and longer follow-up duration, and they're prone for poorer visual outcome. These cases are more active and recalcitrant and need for a more intensive treatment. The point to ponder is maybe newer agents like anti-connective tissue growth factors are required for cleft, and we need long-term RCTs for this. Thank you.
What were you using to treat these clefts?
So, sir, we have been using nothing in particular that only this is being run, ranibizumab, aflibercept, everything we are using. So it's not a particular injection, PRN regimen. So all has been included in this.
Any correlation with the newer ones like brolucizumab or any other?
Actually, in this, we had only one case of which has received brolucizumab, but further studies we can conduct to see that.
Thank you.
Thank you, sir.
Thank you.